anesthesiologist and a statistician. As a statistician, I develop algorithms to analyze neuroscience data. As an anesthesiologist, I deliver clinical care, anesthesia care, to patients who require surgery. Let me tell you a little bit about what that's like. So we place an intravenous line in the patient. We bring them into the operating room. We attach monitors, blood pressure cuff, electrodes to follow the heart. We also place an oximeter probe on the finger so we can track the saturation in the blood, the oxygen saturation. When everything is all set, I give the patient a bolus dose of propofol, and within 10 to 30 seconds, the patient becomes profoundly unconscious. The body goes limp, they stop breathing, and I have to take over their respiration at that point. I then administer another drug which paralyzes them even further, and then once that's taken effect, I place a breathing tube. I make sure it's in the right place. I secure it. I attach up the circuit so I can give them oxygen, or I start the flows of the anesthetic gases, or I start an infusion of propofol, and I maintain them in that state of general anesthesia for the entire surgery. It's pretty wild when you see it, when you think about it. You can actually open the chest, open the abdomen, open a limb, repair the limb, take out pathology in the abdomen, repair the vessels of the heart, sew the patient up, close the wound, and wake them up, and they often come to without any pain. How many people here have had anesthesia? Wow, it's about 80% of the audience. So what is general anesthesia? Well, it's a collection of 4 conditions. So you're unconscious, it's not supposed to hurt, you're amnestic, you're not supposed to form memories while you're having the procedure, and in addition, it's nice if you're not moving around while the surgeons are operating. Now, if you take all those conditions there together, they're also synonymous with death. And so in the realm that I work, that's not a good thing. That's why I mentioned the physiological monitoring that we do, because that's one of the key features of anesthesiology. So it's amazing that having administered anesthesia now for almost 170 years in the United States, it's still considered to be a modern mystery. In fact, as recently as 2005, science considered it still one of the mysteries of modern medicine. And I must say, I developed a schizophrenia about this. So on one hand, I was a statistician who was analyzing data, but I was quite envious of my colleagues, let's say like an oncologist or hematologist. They would have patients that they would see, they would treat their cancers. They would go back to their laboratories and try to come up with new approaches, new therapies, and hopefully find cures. And then they'd also spend a good amount of time informing the public about what they're doing or trying to raise funds to support their research. My work was nothing like that. My statistics research was over here. My clinical research was over here. Or my clinical practice was over here. So what I realized was that perhaps I could start thinking about this problem of anesthesia. And I got the insights from working with the neuroscientist. Because what did systems neuroscientists do? They took a behavior, let's say like memory formation, perception, or vision. They figured out a brain region that was relevant to it. And then what they did was they set out to study it. They tried to see if they could manipulate that. So I figured we could do the same sort of thing for anesthesia. It was kind of like Moneyball. If you think about what happened in Moneyball, Billy Beane is the manager of the Oakland A's. Baseball had been around for years, statistics had been around for years, and he decided to use statistics to actually build a good baseball team. Anesthesia's been around for years, neuroscience has been around for years, but the two really haven't been put together. And that to me seemed like the answer. And a lot is actually known. So if you look here, This is 1937, and even then, it was known that if you administered anesthesia, either an intravenous drug such as pentobarbital or an inhaled drug such as ether, there were very profound changes on the electroencephalogram that occurred. In fact, the brain would go from very small oscillations like this to very large oscillations as the patient became more deeply anesthetized. By the 1980s, it was realized that specific drugs, anesthetics, bound to specific receptors in the brain. For example, propofol, which I'm going to tell you a bit about, binds to GABA A receptors and enhances inhibition. It's the receptors on which it works. Using the ideas of the systematic changes that occur on the electroencephalogram when patients are anesthetized, in the 1990s, many companies came up with indices. These are monitors which actually read the EEG in real time and produce a number. And if you look at those, all of those indices are between 0 and 100. They give you a range which says if you keep the index between these two values, then the patient is adequately anesthetized. And interestingly enough, it was supposed to apply across all drugs and across all types and age groups of patients. So what we decided to do was to do a series of studies in which we got volunteers and also looked at patients in the operating room to see what would happen under anesthesia and study this systematically. So in one of our studies, we actually recorded EEG from volunteers and patients, and not surprisingly, we saw exactly the same thing that had been seen for years. You saw these very, very profound changes on the electroencephalogram when patients were anesthetized. And if you look up at the top, those are very, very typical patterns of anesthesia when a patient is profoundly unconscious. But the part that we added to it was what's over on the right, where you see the red area concentrated on what's the forehead area of the brain. And what we found out is that when those oscillations appeared, when they came on, when the patient was profoundly anesthetized, across that front part of the brain, they were highly organized. They moved in sync together. They were hypersynchronous, in fact. So this gave us an important clue as to what might be going on. So we did a series of animal experiments, and we did some modeling studies. And what we deduced is what is shown in the graph below. That was, the missing part was knowing the receptors was perfectly fine, but you also had to think about the circuits. And the insight that we gained was that those oscillations, which were strongly coherent, were like waves running back and forth between the thalamus and the cortex. The cortex is the part of the brain which is essential for us being able to think and reason. The thalamus is the major way station through which a high fraction of all the information in the brain travels. So if these two areas are tied up, it's going to be very, very difficult to be conscious. But here, I can give you a better idea of what it's like. It's sort of like the following. I'm talking to you now, you hear my voice. It has a collection of tones. Some are high, some are low. They have large amplitudes, small amplitudes. But if you said to me, Emery, this is cool, I'm enjoying this, but I hope you are. I'm enjoying this, but what I want you to do is give me the same talk, but I'm going to give you one frequency, and you have to keep the amplitude the same. So all of a sudden, what I'm saying to you right now becomes wah. Or if you give me a frequency band, it'd be wah, 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 wah. So that's effectively what the drugs are doing. As long as you keep the drugs on, that's what happens. So this is the way that the brain is blocking out the transmission of information. It's just like when you see, if you've ever seen someone who has like an absence seizure, they're there 1 second. Then when the seizure starts, it's very regular activity. They pass out for a second. When the seizure resides, they basically come back. So why is this important? Well, it's important for a number of reasons. The first point I want to make about it is that general anesthesia is not sleep. Now, anesthesiologists, in talking to patients, frequently say, oh, I'm going to have you go off to sleep. Well, there's a reason. they realize it's not sleep, but you can't go to the patient and say, oh, excuse me, Mr. Jones, I'm going to place you in a drug-induced reversible coma for your hernia repair, but I can bring you back, don't worry, all right? That wouldn't go over very well. But it's very important to just go through the distinctions between anesthesia and sleep. So when you sleep, you naturally oscillate between two states, non-REM sleep and REM sleep, and the brain does that about every 90 minutes. During non-REM sleep, roughly speaking, the brain is sort of resting. During REM sleep, the brain is very active. It looks like an awake EEG, in which case there's activity going on, synapses are probably being formed, information which has been acquired while you're awake is being reinforced. What's very clear when you compare the graph on the left to the right is that general anesthesia is not the same state. We bring you into this condition, we hold you there with oscillations which are indeed pathologic. Pathologic because they are not natural. And it's important to appreciate. So that when someone, let's say like Michael Jackson, is trying to achieve sleep by taking propofol, what happens is he doesn't get what's on the right, he gets what's on the left. And remember, the first thing I told you when I described the scenario of what happened to the patient in whom I induced anesthesia was within 30 seconds, he stopped breathing. It's a given. The drugs are too powerful, and they're not designed. In fact, no current sleeping medication is designed to make you oscillate between REM and non-REM sleep. So what's interesting is it generalizes. So the different anesthetics have different signatures. And it makes sense because what happens is they bind to different receptors, they affect circuits differently. So like propofol, if it's ketamine might be higher frequency, sevoflurane, dexmedetomidine, Now, I can see that very well because I do this every day in the operating room. But you can actually project it like this into the spectrogram. It's like just if you took my voice and you created a spectrogram of my voice, and these are actually from the operating room. So anesthesiologists can have in real time indications of the state of the patient's brain that they can read out and really know how anesthetized the level of arousal the patient is in. That's one of the important practical implications of this. We can change the way we dose our drugs, and we can have a more scientifically based approach to thinking about how we manage anesthesia. This is especially important for elderly patients because depending upon which study you look at, anywhere from 25 to 40% of patients over 60 will have some sort of cognitive dysfunction following general anesthesia. Now, clearly, there are many things going on. There's probably a disease process, there's surgery, but anesthesia is likely a contributing factor because the way in which the brain is anesthetized with regular, highly structured oscillations is not natural. The other part to it, too, is that if you think, what I've been telling you about is the current technology. How do the current drugs work? We should take this opportunity to stand back and say, how can we build anesthesia from first principles? We as anesthesiologists have seen it enough, we've learned enough neuroscience, so maybe we should try to go in, develop specific approaches to target specific sites in the brain, and generate the states as we'd like to have them. And I think the implication goes even further, because imagine what happens when you have a patient who is depressed. The brain is in some sense turned down inappropriately. Or imagine a patient who's in a profound coma or vegetative state. The brain is turned off profoundly. And in fact, those waveforms that I showed you are very much like the waveforms that you see in coma because anesthesia is a form of coma, a drug-induced reversible coma. So if we can come up with better ways of bringing people out of anesthesia, we may have very, very concrete ways of helping to treat people who are in coma or helping people who are depressed. Furthermore, clearly, chronic pain is a big issue. We have to take care of pain in anesthesia. This may be a way to gain further insights. And then also sleep, as I mentioned. if we get more refined ways to control the brain for anesthesia, I can foresee a number of ways that we could use those ideas to come up with real therapeutic approaches for having natural sleep. So if you take what I've told you, and we realize that applying the Billy Bean analogy of using neuroscience to understand anesthesia could have profound implications not only for patients having anesthesia care, but could also provide new approaches to thinking about other extremely important problems in clinical neuroscience. Thank you.